Good morning, everyone. I'm Dr. Sal Pacella from San Diego, California. I'm joined by my co-host, Dr. Sam Rhee from Bergen County, New Jersey, as well as our guest host, Dr. Larry Tong from Toronto, Ontario, Canada. How are you guys this morning?
Doing
I'm
awesome.
great. Great to see you guys.
Dr. Jajurikar couldn't be with us today, but we are with him in spirit today. Well, thanks so much for joining in, guys. I got my, it's Bills playoff day. I got my Bills gear, my Bills swag on. So we're going to be cheering on the team later this afternoon. But before we do that, we're going to talk about a very niche topic in facial cosmetic surgery called Festoon treatment. Okay. Before we get into that, let's do a little disclaimer. Dr. Tong.
Thank you.
Tong.
Thank you, Sal. Always classy. This show is not a substitute for professional medical advice, diagnosis, or treatment. This show is for informational purposes only. Treatment and results may vary based upon the circumstance, situation, and medical judgment after appropriate discussion. Always seek the advice of your surgeon or other qualified health provider with any questions you may have regarding medical care. Never disregard professional medical advice or delay seeking advice because of something in this show.
Excellent. So, gents, as we mentioned, we're going to talk about festoons today, and this is a very problematic area of concern in facial surgery and blepharoplasty, and sometimes it's also very confusing. So, what we're referring to specifically for our viewers out there is when you look at the eye. Obviously, we're talking about the lid here and the cheek. And there's an area that connects the lid and the cheek called the lid-cheek junction. And many times as we get older, there's a little indentation there, what we call the tear trough space or the deep crevice of the eye. And there's bags that occur above that space. We're not specifically talking about the bags of the lower eyelid because those are a unique anatomic area. What we're talking about is many times there's a soft tissue bag or a skin bag that goes beyond the cheek line and the lid junction, sort of right in this region here. And it's traditionally very, very problematic to treat. So, gents, just from your practice, what do you, do you see this a lot? Do you have patients come in complaining of this issue a lot?
I'll start off. Yes, this is something where a lot of people think that doing something to the lower eyelid will help. And in my experience, when I do a lower lid blepharoplasty, it doesn't seem to completely fix it. And in conversations with Dr. Rhee, he's indicated that he's able to get good success with it. So I'm going to start off with Dr. Rhee. I'm very curious to hear about what you have found that is successful in treating this.
Yeah. So this topic came up because I found this article on thecut.com written by Valerie Monroe a couple weeks ago, and it says, "What is this bag under my eye?" And as Sal said, so we have the under eye area, which is all we can get bags, and all of us do as we get older. And then the festoons, as Sal said, are like on the cheek. So as you mentioned, Larry, like some people have them very prominently. If you look at Al Pacino, for example, he's someone who has these really big cheek bags that are called festoons. And so there is debate on how best to treat festoons, which are these malar mounds or cheek bags. And I think if they're pretty mild, like for example, when you do a lower lid eyelid lift, I know there's debate. Can you actually get them better with a lower eyelid lift? And I think some of it is, yes, some of this area is just swelling and edema, which is very non-surgical in a lot of cases. But some of it, if you really sort of extend your lower eyelid lift down to the cheek, past that lower eyelid cheek junction, and sort of involve the malar area and do more of a lift that extends to that area, I think you can actually address some of those festoons. I mean, some of them are really severe and you may not be able to, but I think you can in some cases.
Right. So I think the problem and the the tenuous nature of how plastic surgeons approach this, quite honestly, is related to the understanding of anatomy. And and I think that's very important because I have a good friend in Kansas City who speaks quite a bit, Dr. Chris Surik. He's a true anatomist, and we were just at a meeting in Scottsdale for the Aesthetic Society dissecting some cadaver heads, and he has a great comment. He says a fear of surgery or fear of injection is a fear of anatomy. Okay, and I think that holds clear for this anatomic area. And so when you see this festoon, a lot of injectors say, well, let's put some fluid in there. We can't treat this surgically. Let's put a filler of some sort. And that is many times the wrong thing to do. And the reason being is you have to think about this festoon like a bag. I like to think about it like a box, actually. Okay. So if you think about a box, the front of the box is skin. The back of the box is periosteum. Okay. So layer over the muscle. The top of the box is a ligament called the orbital malar ligament, which connects the eyelid space to the cheek space. And then the bottom of the box is something called the zygomatico-central, zygomatico-cheek ligament, depending on which anatomy text you look at. And so to me, the correct treatment of this is you have to release at least 2 layers of this box, the front and posterior layer of the box. And by definition, you're going to go through the top and the bottom of that box to open it up. So if you don't routinely release the orbital malar ligament in blepharoplasty, you're not going to do anything to the malar bag or festoon. If you don't release the zygomatic ligament, you won't do anything either. And you have to really dissect in 2 layers. It's a bilaminar or 2-layer dissection at the skin and periosteum. The second tenet to this is I think you always have to think about. Is my video going down again? Sorry.
Yeah,
I think you always have to think
now.
about. You always have to think about adding some additional device or filler in that area that's going to prevent those ligament, cheek, skin attachments from forming again. And so, to me, that's the key to treating this area. And so, when I do this. It's a much bigger dissection than a blepharoplasty. It's almost a mid-cheek lift. And I liberally use a lot of fat and filler, not filler, but fat as the filler in order to treat that.
So Sal, is your dissection subcutaneous? That's one layer. And what's your other layer? Just on top of the periosteum?
So I first start off, depending on if I'm doing a transconj or a cutaneous blepharoplasty. Usually in the treating of festoons, I'm doing a transcutaneous blepharoplasty through the skin. So my first layer of dissection is subperiosteal. That allows me to kind of release everything at the deepest layer. And then when I'm suspending everything back into position, I'm doing my malar pexy or orbicularis suspension. Then I will do a very wide subcutaneous dissection as well. Now, I think you got to be very careful as a surgeon when you're doing that because that skin can be devitalized very easily. You have to leave a little bit of fat to it. The leading edge superiorly can devitalize a bit if you're not very careful. And, the skin layer, like many things, and the same concepts occur in facelifts, right? The deep layer you can really crank on. The skin layer you want to close just kissing. You don't want any tension on this. And the same thing goes, when I'm treating a festoon.
I think the key that you hit on there is a pretty aggressive subperiosteal dissection where you're really clearing that ligament. And it took me a while to figure out how much of that for something like this you really need. Way more, like you said, than say the typical bleph. And then just putting a lot of filler in there. So just taking that septal fat and just kind of pulling it down usually isn't enough. Like I have to put more than that in there to make sure that those ligaments don't stick back down again, and that you get a really nice, clean, clear like junction. And that is something that it took me a while to figure out how to do that, I think. And honestly, the biggest part of this is suspending everything so that it's not under tension. That's really hard. Like that took a long time for me to figure out. A lot of the videos that you and your mentor sort of presented really helped with taking tension off of that area and allowing for, like you said, a relatively tension-free closure. I am not as aggressive with that subcutaneous dissection. I like leaving orbicularis a little bit more. Like I'm a little concerned about that, but yeah, like I'll stick a lot of fat in there to try to smooth everything out.
Yeah, and you make a very good point about suspension, and some of the videos that Dr. Codner and I made in the past. Where I'm doing things slightly differently now is I'm using laterally a lot of MyTech anchors
Mm,
to support the cheek laterally here.
mm.
And I think that's made a huge difference. And the beauty of those things. So what, for our viewers out there, those are little tiny screws that you can screw in anywhere on the bony anatomy. And they have a 2-layer or 2-needle suture attached to them. So you can really use these as an anchor point. They were originally designed for tendon repairs in the fingers, but works tremendously well. And you can use one of them, you can use 5 of them, you can use as many as you need to get the correct that you want.
So when you do that, when you say no tension, obviously when you're resuspending things, there is a little bit of tension. That's to the deeper layers, I'm
To the
assuming.
deep layer.
And
Correct,
what about the
correct.
skin? Like when you are removing, I'm assuming you're excising some degree of skin when you're doing this transcutaneous approach. Do you try to make it sort of like smooth and taut, or are you just laying it back down and just trimming the minimal amount that you need?
Just laying it back down, trimming the minimum amount. And I think that's where you get into really tough problems when you're not paying attention to that. I think any little bit of tension pulling on the lower lid is a recipe for disaster. Give you an example. I at one point I was curious about what kind of force can pull down a lower lid. Okay, so I have these gold weights that I use for ptosis repair, and I asked my nurse, young gal in her 30s, to volunteer. So I just systematically start taping weights to her lower eyelid and seeing, just how much pull we can get from weight. So you know what the weight limit for displacing the eyelid in a 35-year-old woman was in this particular experiment? It was 2.5 grams. So that's
Oh,
2 paper
wow.
clips. Okay.
Mm.
And that's in somebody that has good lid position and good ligamentous, firm positioning. It's somebody who's 70, 80, 90, just think, and you just blow at the eyelid and it's gonna get out of position. So I think that the non-tension closure is a critical tenet.
Yes. So do you
What?
think that aside from that, that the non-tension closure on the skin, what is, how would you describe to the viewers as what the volume is doing? Because you've described it, but conceptually, what are you actually doing with that volume?
So as I mentioned, that anatomic box, right? And so what we're doing when we're putting filler in there, particularly in the cheek or the deeper periosteum, is we're just destroying all of the potential attachments of the box. The box, the prezygomatic space, is what a festoon is, what a mailer bag is. And so if you just destroy the box and you recreate the space, these attachments won't get back. Now, let me also say this. This is not a foolproof strategy by any means. And anybody that comes into my office that has a potential festoon that I'm planning surgery on, I try to prepare them for some sort of revision if needed. Just for example, 2 weeks ago, I had a gentleman I did a lower lid blepharoplasty on and a festoon treatment about a year and a half ago. And I've been following him every couple months and hoping his swelling would get better. And he still has a little bit of residual festoon there, and I just resected those directly 2 weeks ago. And, did I make him 100% better after the festoon? No, but we probably got about 85% of the 85% there. It's substantially improved. And I'm hoping with a little bit of a direct excision, it'll get better. And so I think, we have to kind of approach this much like ptosis repair. I say to patients, ptosis repair, it's not 100% science. We got a revision rate of about 10%. We may have to take or adjust things a little bit more, but that's okay. We're trying to make it perfect, but we got to give it the time and the swelling to go down. So
What do you think about the non-surgical treatments that this article recommends, like intralesional tetracycline or ultrasound or radiofrequency? Like, do you feel that these are effective treatments for festoon management?
So excellent question. So, I am a section editor for the Aesthetic Surgery Journal, and part of my job as being a section editor is I review a lot of these articles. And so, um, if anybody is out there interested, if you just search my name in Festoon, there's a podcast that comes up about this topic, and there's several review articles about this with commentaries. And there's a couple papers out there that show some modest result improvement with minimal to modest festoons utilizing tetracycline and radiofrequency. And I think, if you have mild festoons, does it make sense to go through a big open procedure? Possibly not. I mean, you can always try a non-surgical treatment. If things get worse or if things get better, that's fantastic. If they get worse, then that, the option is surgery. In advanced festoons, where people are, the skin is folded, there's chronic edema, it's visible from across the room, none of this non-surgical treatment really works all that well, in my opinion.
I have one thing to add to that with regards to the tetracycline. Conceptually, that type of procedure is something that I have done, and it's been used most effectively, as you said, on mild festoons. Now, it's not injecting tetracycline. Now, for the viewers, tetracycline is an antibiotic, but if you inject it under the skin, it's very inflammatory and it causes some scar tissue, and that's how it is thought to improve the festoon. And so I've done something a little bit different. I've actually used a fat grafting cannula, and I've just put it, made a very, small needle point incision in that area. And I've run the rough flute of the fat graft cannula along the underside of the skin. And that causes some degree of inflammation and scarring down. And so that's something that I found is, very simple and easy to do. It doesn't always work though. I would say it works in maybe about 60% of the times. So that's also something to consider, that I've found success for that. But yeah, in the bigger ones, I don't think that works.
Have you seen filler making these worse? Like someone who has had filler treatment who comes to you and says, "Oh my God, that made it like 10 times worse."
Yes, because
Almost weekly, I see this.
Yeah, because it seems like it's an area that just likes to swell. Patients will say that it's worse in the morning and it's better in the evening, which implies that it's, because they're lying down and the fluid gets redistributed throughout the body, that swelling of the face makes it worse. So if you're going to put in filler, which is something that's hydrophilic, which attracts water, that's probably going to make it worse. In that article that Dr. Rhee was talking about, it also mentioned that having blepharoplasty can make it worse. I think that's a byproduct of the swelling that occurs with the surgery. I think I don't think the surgery actually, if you don't do anything specific for it, I don't think it makes it worse, but it does give you a period of time where the festoons may look worse, but then goes back to its original state eventually.
Right. But the act of injecting a filler inside there, to me, shows complete non-understanding of the anatomic problem here, right? So like when you inject filler, all that's going to do is swell the box. You're doing nothing to open up the lid of the box or the front of the box, right? And so it just routinely doesn't work. And that's why you see a lot of patients come into the office with, disappointed with, their dermatologist or plastic surgeon who injected it, or, nurse inject.
I mean, in most of the cases that I've seen, when I'm doing, lower periorbital filler injections, you're not injecting subcutaneous. You're injecting either right on the periosteum or right, like basically I'm touching bone necessary. Like when I'm injecting filler, like I want to be right there. I can't imagine anyone actually injecting festoons with filler. You're right. It makes absolutely no sense to me.
I think what they're trying to do is sort of inject the areas that aren't as full and sort of trying to hide it. But I think the net effect is that it just makes the festoon look worse.
Any other thoughts about festoon treatment? Advice to people who have festoons who are thinking about doing something about it, other than going to San Diego and seeing Sal, because that's what I would do.
No, more so
right.
Sal.
You can't operate on Americans. So
Oh yeah, I can. Come on up. We take your American
Oh,
dollars.
really? I thought that was different. I thought that was different. Oh, great. I thought that was a change. Maybe. Fantastic. Yeah. I mean, I think the key here is really, understanding the problem, understanding the anatomy, and the other issue is that most of the time, patients who have festoons have other anatomic or morphologic variants that make their blepharoplasty very challenging.
Yes.
That invariably means prominent eyes. Okay. You don't see people with deep set eyes getting a lot of festoons. People with big cheeks don't necessarily get festoons. It's people with protruded cheeks, with very prominent eyes, with loss of tissue volume that tend to get this. And if you're not paying attention specifically anatomically to these things, your surgeon is going to disappoint you potentially.
Good points. All right. With that, thank you so much, Sal, Larry. Always a pleasure. Really hope the Bills pull it out
Go
today
Bills.
with the Chiefs. All right.
All right. Appreciate it, guys.
Take care.